You're watching McLaren Port Huron today's health program. We are learning all about imaging services that are available here at McLaren Port Huron. And to learn more, we're speaking with board certified radiologist Stacy Ries. Dr. Ries, thank you so much for joining us today.
Absolutely, pleasure to be here.
Great. Can you talk a little bit about the services that are available here at McLaren Port Huron?
Sure. So for screening of the general population, we do perform 2D mammogram and both 3D mammogram. That's a choice that's up to the patient themselves and in combination with a discussion with their physician. We can talk a little bit about tomosynthesis or 3D mammogram shortly. Mammogram is still the gold standard for screening, and National Cancer Institute study in 2015, it showed that since we instituted mammography across the U.S., there's been a decrease of approximately 40% in mortality rate from breast cancer. So it really is the gold standard and something that women should do annually. The American College of Radiology recommends it annually after the age of 40 unless the patient is high risk, and then they should be screened with their physician to have screening earlier. The other colleges have come in concert with that, being the American College of Gynecology has also recommended at age 40, and the National Cancer Institute is now saying it's up to the patient whether they want to be screened before 50 or not.
Okay, great. So it can be a little bit confusing for a patient, but really having that partnership with their physician helps guide the way.
Absolutely. All the different colleges have different recommendations, but certainly the people who deal with women's health, being radiology and American College of Gynecology, recommend at age 40.
Okay, great. So let's talk a little bit about mammograms. How does that technology actually help you to view the breast tissue?
Sure. So we use a small amount of radiation to develop images of the breast based on the different compositions of the breast and different densities. Each woman has a different amount of fibroglandular tissue and fat, and the small amount of radiation will generate an X-ray, and that will generate an image for us and determine what is in the patient's breast, whether it be a mass or calcifications, some of which are benign and some of which are malignant, and then asymmetries, and that's what we typically look for to determine if there's a cancer present or not.
Okay, so I know sometimes patients will get called back, which can be stressful for them, but I know there's a really good reason why you would call someone back for additional views. Can you talk a little bit about that?
Absolutely. So diagnostic imaging is when someone is called back. So we do screen the general population. That's when you come in for your annual mammogram. And diagnostic is when we found something that could potentially be a problem. However, about 80% of those should be absolutely nothing, and then 20% may go on for further evaluation. The things that I mentioned before, the asymmetries, calcifications, those are things that can be benign, but they also can be malignant. So if we see something that's new from a prior mammogram, one of those, or a mass, or what we call distortion, pulling in of tissues, that's when we would want to further investigate. So for calcifications, we do specific views, magnification views, and that allows us to look at the morphology and how those calcifications are distributed through the breast, some of which we can tell certainly that are benign. Some calcifications occur in cysts and they layer, and we can send the patient home and say these are certainly benign. Some are classified as high risk, and those ones we would need to biopsy. And some are very suspicious. Those ones we can tell as they branch through the ductal system. I'm sure people have heard of ductal carcinoma in situ. We can watch it go through the duct on those magnification views. And some are indeterminate, and there will follow up in 6 months.
Now, has the 3D mammography improved the callback? Can you talk a little bit about the difference between
Certainly.
2D and 3D?
Certainly. So it has significantly improved callback rates. So the other thing we were talking about was focal asymmetries or asymmetries. That can be just summation of breast tissue on itself, since women, we'd only view typically in 2D unless we're doing a 3D mammogram. In 2D, we can have from 2 views, front to back, breast tissue that's lumped upon each other, and it looks like a mass. So in 3D, what we do is we essentially do like a CT, or we'll do sequential slices through the breast, and it'll allow us to scroll through the entirety of that tissue and see if there's anything that persists, such as a mass, or if that just looks like smooth tissue throughout the entire breast, and that will decrease our callback rate for both of those. Also decreases our callback rate for calcifications, because we can see if they're in a group or if, again, like in asymmetry, they're superimposed upon each other. and just scattered throughout the breast as most benign calcifications are. In terms of callback rates, other studies that have been established, one study at Stanford at 2015, they demonstrated a decreased callback rate of 40% from 2015 to 2018.
That's great. It's amazing how the technology just continues to advance.
Absolutely.
One of the other technologies that a lot of people hear about is MRI. So can you talk a little bit about MRI for imaging and what's different about that?
Sure. So MRI in general, it has increased sensitivity to the detection of cancer. However, it's not a fail-safe. Every modality that we use, and we do use multimodality imaging, we do use ultrasound, MRI, and 3D and 2D mammography. They all have their faults and they all have their strengths. MRI is wonderful for certain types of cancers. We inject contrast into the patient and we take images at different time points, and we can see if the cancer, if it has washout enhancement, it'll take up contrast and then wash out quickly, and that's very suspicious. And if it has persistent enhancement where it just takes up and goes along, we can tell that that's pretty much a benign thing that doesn't need a biopsy whatsoever. However, early cancers such as ductal carcinoma in situ may not have a lot of enhancement, or lobular carcinomas may not have a lot of enhancement either. So there's a reason why we choose to do mammography and MRI, so that we can catch early cancers and then we can find other cancers that may be occult on mammography with MRI and supplementation.
So there's a lot of different technologies that you use, so it really depends on the patient, what you need, whether it's ultrasound or MRI. And you do use MRI sometimes for like the needle biopsy?
We do.
And the stereotactic
Yes.
as well?
MRI is approved for screening, diagnostic, and for biopsies. If we see a mass on MRI, we like to do a second look ultrasound because it's a more comfortable biopsy for the patient. We want to make the patient as comfortable as possible. So we'll do an ultrasound to see if we can find that mass. And if we do, we'll do an ultrasound guided biopsy in the office. And then if we don't, we'll do an MR guided biopsy. That we can certainly do here. That's new technology we've had within the last couple years. And we can watch the MRI show exactly what occurred on the initial screening or diagnostic MRI when we're doing the biopsy. And then we place a needle and we take another MRI image to ensure that the needle is right where the biopsy needs to be performed. And then we take a 360-degree radius biopsy to ensure we're getting all around the tissue and leave a marker for the surgeon to know if it comes back a malignant etiology, then we know where we were and we can localize that for the surgeon. And then if it comes back a benign etiology, then we know for future MRIs that everyone should just leave that alone. It's a benign thing and don't worry about it, and the patient won't get recalled again.
That's amazing. A lot of advancements in technology, which really is great for our patients and our community here, that they can stay right here at McLaren Port Huron and get all this advanced treatment that's available to them.
Absolutely.
That's great.
We have board certified and fellowship trained breast imagers that are here. So we're very proud of that.
That's amazing. Thank you so much for sharing this information with us. It's very valuable to our audience. We appreciate it.
All right, great. Thank you.
Thank you for watching McLaren Port Huron Today's Health. If you have any questions about the program, you can call us at 1-800-228-1484 or email us via our website at www.mclaren.org/phcontact. You can order a free copy of the program and access reliable health information through our website at www.mclaren.org/PHTH. As always, be sure to tune in next week for Today's Health. Today's Health is brought to you by McLaren Port Huron. McLaren Port Huron, doing what's best.